the the determinants of heart function, the normal values for various heart measures, as well as the overlying principle regulating heart functions, which is the Frank-Starling principle. So the first thing we need to talk about when we talk about the norm values is what norm means. Norm does not mean normal. Norm is a statistical phenomenon based off of the bell-shaped curve that you see here, where we are talking about a range of numbers that go from really the -1 to the 1 within this curve being what's referred to as norm, or the average normal, where people fall within one standard deviation of the average within the population. Anywhere up to a plus or minus 2 is considered within the normal range. So you can have a very wide range of values for normal heart functions based off of where you fall within this normal curve. So the first norm that we have is heart rate. Heart rate is abbreviated HR. The next norm that we have is what's referred to as stroke volume. Stroke volume has two different abbreviations, SV, or sometimes seen in the literature as V with a dot over it. Anytime you see a value with a dot, it's an indication of per minute. We next have measures of overall heart function, which is cardiac output and ejection fraction. Cardiac output, which is mathematically abbreviated C.O. Where in the literature we will see it as what's referred to as perfusion, Q with a dot over it. The cardiac output is an indication of how much flow is exiting the heart per minute, whereas ejection fraction is the determinant of how much blood is exiting the heart relative to how much is entering the heart via venous return. It's the cardiac output and the ejection fraction which will ultimately provide us with overall determinants for heart function and relative cardiovascular health. When we talk about ejection fraction and when we talk about cardiac output, we have to talk about what's usually referred to as systole and diastole. When we talk about systole and diastole, what we're talking about is two distinct things. We're either talking about the volumes, which are usually abbreviated ESV in systolic or EDV in diastolic, which is simply the amount of blood that's moving or the amount of blood that's held within the heart at the end of each cycle. Or we can talk about it based off pressure differences. Within the pressure differences, we refer to it as being SP, systolic pressure, or DP, diastolic pressure. The systolic and diastolic pressure are sometimes mistakenly referred to as blood pressures that we read with the blood pressure cuff, the sphygmonamometer, but those are not the actual blood pressures. What we get from the sphygmonamometer is not actual blood pressure, it's the pressure of resistance within the lumen, which we'll talk about later. So let's talk about heart rate. Heart rate is the frequency of heart contractions within a given cycle. This heart rate is highly variable. It's highly variable based off of what we usually refer to as the fitness of the individual or the health status of the individual. It's also highly variable based on the body position, the level of stress being encountered at that given moment, and whether or not there's a change in posture or a change in blood return to the heart. Because it's highly variable, it's kind of a misnomer to say that we have a set standard heart rate. However, we typically consider the norm heart rate to have a contraction of about 1 to 1.2 contractions per second. And we have two distinct ranges that we deal with. We have what's referred to as the rhythmic range. That's the range that the heart can handle within its own kinematics. Then we have what's known as the intrinsic range. The intrinsic range is the range based off of rate of depolarization. The intrinsic range gives us a rate of 70 to 92 beats per minute, or heart cycles per minute, whereas the rhythmic range gives us a range rate of 45 to 185. Because of the high variability in heart rate, people can have normal heart rates that most books may classify as being either bradycardic, too low, or tachycardic, too high. There are a couple of clinical research papers out looking at endurance athletes who've had rhythmic ranges in the 30s with no abnormal effect to them, and non-endurance athletes who have been able to have maintained sustained heart rates into the 220s with no abnormal effects occurring. The rhythmic range will be the overall determinant of heart health, if you want to look at it that way, based off of the Frank-Starling principle, which we'll talk about in a little bit. So how do we measure this heart rate given the variability that we have? We're going to measure the same way, however, the means by which we classify it will differ based off of what we're actually looking at. The one that most people are typically familiar with is what's referred to as the heart rate at rest. That's HR subscript rest. This is the heart rate that you have when there's no external stimulus. This is a tested heart rate in which the person is put into a darkened room with no sound in what's referred to as a semi-recumbent. That means that they're seated with their legs out in front of them posture, where they're left there for a period of about 10 to 15 minutes, after which the heart rate is measured. The whole issue here is that there is no stimulus to cause any change in heart functions that we saw based off of changes in the SA node depolarization rate or the contractility rate of the myocardium. What most people confuse as being a rest heart rate is actually the non-exertional heart rate. This is the same exact heart rate that would be the resting heart rate if we allowed external stimulus there, meaning that there is no exertion going on, but there is external stimulus. This is you guys sitting, listening to a lecture, or sitting watching a movie, or reading a book, where there's no actual stress going on. However, once you try to calculate your heart rate in those situations, it is no longer a resting non-exertional heart rate, because simply trying to count the beats of contractions becomes an exertion. Because when we talk about non-exertion, we're talking about both not physical nor psychological exertion whatsoever. HR max is the maximal maintained sustained heart rate for about 180 seconds or about 3 minutes. Once again, this is a tested heart rate. It's typically done in what's usually referred to as a stress test or in what's usually referred to as a VO2 max test. What most people know, however, is what's referred to as the age predicted max. The age predicted max is an estimated maximal heart rate that is mathematically based on age only. It has a very good correlation, however, a very low degree of interaction with true maximal heart rate. There are two distinct equations that can be used for determining age predicted. There is 220 minus your age, and there is 208 minus 0.7 times your age. Whenever you're doing any type of activity, whether it is physical or psychological, you are working what's usually referred to as a sub-max range. That's simply any heart rate that's above your resting non-exertional and below your max. So if I ask you to sit here and determine what your heart rate is, you are actually doing what could be considered to be a sub-maximal heart rate determinant, as you are having mental activity, even though it's not really physically active. The last measure of heart rate is a mathematical representation of intensity. We use this to determine intensity of physical activity, and it's referred to as HR reserve or HRR. And it's a mathematical percentage based on the difference between your maximal heart rate, either true max or age predicted, and your resting relative to what you want the person to be at. So what we do is you basically say, okay, if your resting heart rate is 80 and your maximal heart rate is 180, and we want to work at, say, 60% of your reserve, we go 80, you're resting, plus 0.6, 60%, times 180 minus 80, which then gives us 80 plus 0.6 times 100, 180 minus 80, or we get 80 plus 60, 0.6 of 100. So we have an HRR, or heart rate reserve, of up to 140. We usually have a low end and a high end. So if we were saying we're going to work from 50 to 60% of HRR, then we're going to have a heart rate range of 130 to 140. Stroke volume is another measure that we'll be dealing with. Stroke volume is the amount of blood moved with each contraction of the ventricles. We look at it in terms of an equation. Stroke volume is equal to the end-diastolic volume minus the end-systolic volume. On a norm, it's approximately 7 milliliters per beat, or 0.07 liters per beat. The other means that we can look at stroke volume is in relationship to heart rate, based off of what's referred to as cardiac output. Cardiac output is the amount of blood moved per minute of the heart function, sometimes referred to as minute volume of the heart. Sometimes it's also referred to as perfusion rate. This perfusion rate is specific to tissue flow. In general, cardiac output is physiologically regulated to maintain a stable output, where the stable output is equivalent to the total volume of blood per minute by modifying heart rate and stroke volume in an inverse proportionality, as cardiac output is equal to stroke volume times heart rate. In this relationship, heart rate is equal to cardiac output divided by stroke volume, and stroke volume is equal to cardiac output divided by heart rate. The norm values that we have for cardiac output is approximately 4.2 to 6.0 liters per minute, with the norm average being 5 liters per minute. Now, what we have to remember is that this norm value is gender, size, and level of activity dependent for the individual, which means that no individual will have a set cardiac output that is equivalent to anybody else. The larger the person, the greater the cardiac output. The more physically active the person, the greater the cardiac output. Men will typically have a larger cardiac output than women. Going hand in hand with cardiac output in measurements of overall determinant of cardiac health function is ejection fraction. Ejection fraction is the amount of blood that is ejected from the heart relative to the amount that is filling the heart. We look at it in terms of an equation. EF, ejection fraction, equals stroke volume, SV, divided by end diastolic volume, EDV. This is represented as a percentage, where the higher the percent, the better the heart is functioning, meaning that stroke volume and end diastolic volume are roughly the same, whereas lower percentages are worse off, meaning that stroke volume is much less than the end diastolic volume. That has to do with the fact that stroke volume is equal to end diastolic volume minus end systolic volume. And so what you want to have is you want to have as close of numbers as possible, meaning that 100% is an indication of all blood entering, leaving, whereas, say, 80%, which is an indication of congestive heart issues, where you are losing 20% of the fill from the ejection. This is really the primary means to measure the contractility and efficiency of the heart. Within all of these norms, we have to remember that there's this rhythmic contraction issue as opposed to just the intrinsic contraction issue. The rhythmic contraction issue is simply the indication that the heart contraction can be under rhythmic control, which means that the expansion of the heart itself will lead to a heart contraction. It's based off of what's referred to as Frank-Starling's law, which is an indication that the pre-stretch of the myocardium leads to the cardiac muscle contracting, and it's based off of a length tension issue within the cardiac muscle. which leads to two distinct questions. What is the length tension issue, and how does Frank-Starling work? The length tension issue simply tells us that the greater the stretch, the more length we have within a muscle, we will get a greater amount of elastic return, which means we have less active force being required from the myocardium in order to produce a contraction. What this means is that if we allow the heart to fill more, we get a greater rate of return, meaning we get more contraction force and more volume exiting per contraction. Within the Frank-Starling, we have distinct issues. The distinct issue is related to the stretch of the cardiac muscle being proportional to the strength of the contraction, as long as the stretch occurs prior to the wave of contraction occurring. Meaning that if we allow the heart to fill more, the contraction following will be stronger, leading to a greater volume being expelled from the heart or ejected from the heart into the arterial side of circulation. Because of the proportion of blood found in the arterial side relative to the venal side is going to lead to a greater amount of venous return, thus subsequently more filling and improving overall heart functions. In this law, we get two distinct adaptations. The two distinct adaptations are going to relate to modifications in heart rate and stroke volume, mainly because we want to keep cardiac output stable. The responses are proportional to the venous return and related to the total peripheral resistance which the ventricles have to propel against. In general, an increased venous return leads to an increased stroke volume and a reduced heart rate, whereas a decreased venous return leads to a decreased stroke volume and an increased heart rate, all in an attempt to keep cardiac output stable. Chronically, this leads to two distinct ventricular adaptations. We either get a greater volume of the ventricles, or we get a greater muscle amount of the ventricles, meaning that we get what's usually referred to as ventricular hypertrophication. This chronic adaptation is all based off of arterial compliance. That is the ability for the arteries to expand the diameter to allow for greater flow through. So if we look at this in terms of an impact, it's based on the relationship between end-systolic and end-diastolic volumes, which is going to be influenced by venous return, total peripheral resistance, and total blood volume. If we get a greater cardiac muscle stretch to the point where the muscle is about to tear, we will get a much, much greater force of contraction, which means we get a compensatory change in the relationship between end-diastolic volume and end-systolic volume, which means we get an increase in ejection fraction. What this is going to ultimately lead to is an increase in ventricular volume, which means that the person at rest will have a much, much lower heart rate and a much, much higher stroke volume, and thus a more efficient heart. However, if the cardiac muscle has to overcome a greater amount of total peripheral resistance as opposed to muscle stretch, then we end up getting a greater amount of active force contraction. The compensatory response here is a change in the end-diastolic volume to end-systolic volume ratio that diminishes ejection fraction. The compensation here is hypertrophication of the myocardium, meaning that we have to get more active muscle contracting in order to produce enough force to overcome the initial resistance to flow found in the aorta. This is all due to an increase in total peripheral resistance, whereas we get an increase in volume of the ventricle when we allow for a greater amount of return and a lower peripheral resistance to flow exiting the ventricle. The two typically are seen as counterproductive to each other. We usually see the left ventricular hypertrophication in people who are highly sedentary or people who are predisposed to certain conditions, or people who have genetic issues related to a specific gene known as actin 3, which causes left ventricular hypertrophication. The other type of people that we're going to see who may experience this left ventricular hypertrophication are people who are highly athletic in what are usually referred to as the resistant sports, or people who do not do sub-maximal resistance training. Anybody else will see an increase in ventricular volume. What we end up getting overall from this Frank-Starling relationship is that with an increase in stroke volume and ejection fraction, we get an increase in cardiac function, typically due to ventricular enlargement. This ventricular enlargement is a compensation to the response of increase of venous return. However, if we get the increase in total peripheral resistance, we have to increase the force of ventricular contraction, particularly the active force, which is going to mean that we're going to need more muscle there. If we increase the amount of muscle because we only have so much space that the heart can take up, we automatically diminish stroke volume. This increase of muscle mass is the ventricular hypertrophication. This ventricular hypertrophication becomes problematic within distinct populations, particularly the highly sedentary, the geriatric, the genetically predisposed, what are usually referred to as athletic individuals that only train at max effort. All of these people will end up having the negative Frank-Starling effect, diminishing the efficiency of cardiac cycling, leading to a diminishment of ejection fraction, a diminishment of stroke volume, and an increase of heart rate, particularly at rest. Now, before we get further on, we have to remember that max heart rate does not fluctuate very much, but resting heart rate will fluctuate greatly. So what's going to determine this overall heart function? It's all about energetics and the dynamics of bulk flow. The dynamics of bulk flow simply means that everything is going to move in one direction as a single unit, regardless of what's making up the medium of flow. These determinants are established via the reservoirs. The pressure reservoir found in the arteries based off arterial compliance, and the fluid reservoir based on the total amount of blood found within the veins. And so if we were to look at it in terms of a flow chart of the controlling mechanisms here, we have autonomic tone, which is going to set peripheral resistance, and we have total blood volume. Total blood volume is going to be dependent upon your hydration status, your status of injury, and your status of illness. We also have issues of gravity and muscle pump, which is going to be an indication of your activity and your body position. That is, can you force blood back to the heart, or is it staying within the periphery? This peripheral resistance and this total blood volume work hand in hand to each other. Muscle pump and gravity are going to influence where we have collection of blood based on what's known as the proprioceptive and baroreceptive responses. All four of them are going to work together to form venous return, which initially sets the volume load on the heart. The volume load on the heart is going to cause a stretch within both the atria and the ventricle. This stretch within the atria and the ventricle will lead to the Frank-Starling adaptation. The autonomic tone is going to dictate the amount of contraction force and the ease of depolarization that occurs. When we couple the elastic return and the energetics of contraction, we're able to establish an ejection pressure. This ejection pressure is dependent upon the amount of peripheral resistance and aortic compliance that must be overcome in order to move blood out of the ventricles and into the aorta or into the pulmonary trunk. This rate of contraction determines the heart rate. The amount of fluid moved due to the issues of ejection pressure being overcome and contraction force being generated to overcome that pressure establishes the stroke volume. The ejection pressure and the stroke volume will be the determinants that establish ejection fraction, whereas the heart rate and the stroke volume will ultimately determine the cardiac output. Notice how cardiac output and ejection fraction are the end determinants of this pathway. So what are the principal events that we see within the contraction? We have the systole. The systole is the action within the heart in which a change of pressure will allow for blood to be ejected from the ventricles into the arterial system. And then we have the diastole, which is the action in a change in pressure, which will allow for the ventricles to fill. The difference between these two establishes the efficiency by which the heart will function. What we have to remember is that we can never have the entire heart contracting at once, for the simple fact that it functions as a hydraulic pump, and if we have both the atria and the ventricle contracting at the same time, where would blood go?